All right, let's talk about something you are absolutely going to see on the wards, malignant biliary obstruction. We're going to walk through a really practical guide to endoscopic stenting, basically everything you need to know to get up to speed fast.
Okay, so what's the core problem here? Well, at its heart, it's a plumbing issue. You've got a tumor that's literally squeezing the bile ducts shut. All that bile gets trapped and backs up into the liver, and that backup is what causes all the problems we need to fix, usually with a procedure called an ERCP.
You've probably heard the textbook phrase painless jaundice, and yeah, it's a massive clue. But why does it happen? Well, all that backed up bile is loaded with bilirubin, and that's what turns a patient's skin and eyes yellow. So our job is to play detective, figure out exactly where that blockage is, and, find a way to open it back up.
So here's our game plan, and we're going to tackle this just like you would with a real patient. First, we'll get the lay of the land, the anatomy. Then, we'll ask the big question, do we even need to intervene? After that, we'll pick the right tool for the job, see how that plays out in different scenarios, and finally, we'll talk about what to do when things don't go according to plan. Let's dive in.
First things first, the anatomy. Before you can even think about what kind of stent to use, you have to know where the problem is. Seriously, this one detail is the first major fork in the road for your entire management plan.
Now this is where it gets really interesting, because the location basically gives you a huge clue about what kind of cancer you're dealing with. If the blockage is distal, meaning lower down, your first thought should be pancreatic cancer. But if it's way up high near where the ducts leave the liver, what we call the hilum, then you should be thinking about cholangiocarcinoma, sometimes called a Klatskin tumor.
Okay, so this brings us to a really central question. Does every patient with a blockage need a stent? And the answer is no, it's not automatic. The decision to go ahead and place a stent really falls into one of two very different buckets.
And here are those two buckets. On one hand, you have palliative drainage. This is for patients whose cancer can't be cured by surgery. The goal here is all about quality of life, relieving that awful itching, clearing up the jaundice, and just getting them strong enough for chemo. On the other hand, you have preoperative drainage. In this case, the cancer might actually be curable with surgery, and you're just placing a stent to get the patient in better shape for the big operation. This is a little controversial, I should say, but it's often done if there's an infection or a long wait before surgery.
So you've made the call. We're going to stent. Now it's time to open up the toolbox, because this is definitely not a one-size-fits-all kind of deal. The stent you pick can have a huge impact on the patient down the line. Let's break down the main options.
This right here sums up the biggest trade-off, and it all boils down to one word: prognosis. If a patient has a limited prognosis, let's say 3 months or less, a simple plastic stent usually does the trick. But if they're expected to live longer, then a self-expandable metal stent, or SEMS, is the way to go. It just stays open for so much longer, which means the patient can avoid coming back for more procedures.
But wait, there's more. Even with metal stents, you've got choices. An uncovered stent is basically a bare wire mesh. It digs into the tumor tissue, which is great because it's not going anywhere. The problem? The tumor can eventually grow right through the mesh. A covered stent, on the other hand, has a lining to stop that from happening. But that makes it slicker, so it's more likely to slip out of place. It's a classic procedural trade-off, right?
Okay, let's put it all together now. We're going to take everything we've just talked about and apply it to the two big scenarios you're going to encounter: distal blockages versus those tricky hilar ones.
And here we are again, back to the most important question you have to ask yourself at the very beginning. Is the blockage down low, near the pancreas, or is it way up high, at the hilum? Because that one piece of information changes your entire game plan.
So, for distal obstructions, the rule is thankfully pretty simple. It almost always just comes down to the patient's prognosis. If they're expected to live longer than 3 months, you go with a metal stent for that long-term durability. Less than 3 months, a plastic stent is a totally reasonable and cost-effective choice. Simple as that.
But hilar obstructions? Now that's a whole different beast. Here, the priority isn't so much about prognosis, it's about mechanics. You almost always want an uncovered metal stent. And why is that? Well, if you put a covered one up there, you'd block off important side branches and could actually make things worse. The big goal is to drain at least half of the liver, which often means you have to put in 2 stents, one for the right side and one for the left.
Of course, no procedure is perfect. Stenting is an amazing tool, but you've got to be prepared for when things go wrong. So let's wrap up by looking at the most common complications and what you need to do about them.
Think of this table as your high-yield cheat sheet. The big 3 problems are occlusion, migration, and cholecystitis.
So, if your patient with a stent comes back with jaundice or a fever, your first thought should be a blocked stent. If they're complaining of new abdominal pain, you should worry about migration. And if they still have their gallbladder, that classic right upper quadrant pain could mean cholecystitis because the stent is blocking their cystic duct.
And for that most common long-term problem, occlusion, there's a really neat solution. When a stent eventually clogs up, the fix is usually to just go back in with another ERCP and place a brand new stent right inside the old one. We call it a stent-in-stent technique, and it's a super effective way to get the bile flowing again.
Okay, so if you only remember 3 things from this entire explainer, make it these. 1. Know why you're placing a stent. Is it for palliation or to get ready for surgery? 2. For distal blockages, prognosis is king. That tells you plastic versus metal. And 3. For hilar blockages, it's all about location, location, location. You need to maximize drainage, usually with an uncovered metal stent. If you nail these concepts, you'll be in great shape.
And that's our deep dive into biliary stenting. But here's something to think about. While ERCP is the workhorse right now, this field is always changing. New things like EUS-guided drainage are coming up and are becoming really powerful tools. So the way you manage this problem will definitely evolve throughout your career. The key is to stay curious. Thanks for tuning in, and we'll catch you on the next one.